Of the day, I welcome all our viewers to our regular session of IJCCM Best Article of the Month, Editor's Choice and Author's Voice. So, the last subscription of IJCCM, we have got a beautiful article by a panel of authors. The article is about the clinical utility of target heart rate control in septic shock. A systematic review and meta-analysis of randomized control trials with trial sequence analysis is a phenomenally beautiful study, very up to date, and it is a very practical study which is going to help us all intensivists in our bedside practice. And to discuss regarding this article, we have with us two very eminent critical care physicians across the globe. We have with us Dr. Riddhi Kundu. He's a consultant at Department of Critical Care Medicine, Ruby Hall Clinic at Pune. And the editor who accompanying him is Dr. Kiran Gudivada. He's a consultant at Department of Intensive Care at Canberra Hospital, Australia. Thank you guys for joining in. And I welcome all of you to the IJCCM this session. And first of all, go to Dr. Riddhi actually. So why did you undertake this systematic review and meta-analysis? Just an update from you. Over to you, Dr. Riddhi.
Yeah, so thank you, Dr. Pragyan, firstly, for the invite. And I would just like to thank all my co-authors as well for this systemic review, because any systemic review and meta-analysis is a teamwork and not one's individual work, right? So the reason, as you asked, that's a great question. Why did we undertake this review? So generally, when I come to doing any sort of research, what I try to do is try to do the research based on whatever clinical situations that we usually deal with in the ICU, right? And I usually try to derive, or we as a team try to derive some of the answers to the situations that we face. And often, like when I was doing my residency, I remember back in, I think, 2015, we had this Moderator trial, which showed that if you use esmolol in somebody with septic shock with inappropriate tachycardia, the mortality goes down tremendously. So obviously that trial was heavily criticized because there was a very high mortality in the control group, in the septic shock group, who didn't receive heart rate control. And that was one of the major criticisms of the trial. But even after that, in the clinical situation on and off, we do face situations where you think that you have taken care of rest of the things like fluid deficits, pain, discomfort, anxiety. And even after that, the patient continues to have a heart rate in the 150s, 160s. And somehow you feel that maybe that tachycardia is actually doing some harm to the patient, especially to a patient with septic shock in the long term. And then you're not really sure whether, because the patient is hemodynamically unstable also, you're not sure whether to give a beta blocker or not, right? And then there have been multiple trials after that. They've tried to address the same issue. Recently, we had the Stress L-RCT, which was published last year. So I felt that it's time that somebody actually takes into account all these trials and tries to find out what is the consensus in terms of, if we take all these trials together, what is the final effect size that we get after including all these trials. And that was basically my clinical question that basically led us to explore this as a possible research question in this systemic review and meta-analysis.
Wonderful. We got it actually. The way we face patient day in and out, and almost 80-90% of all are having some sort of tachycardia throughout our ICU stay. That gives us, sometimes the tachycardia in the monitor also transmits to the physician who's seeing it also.
Absolutely.
So, absolutely. So the article is phenomenal. Can you tell us what are the main findings in your meta-analysis?
So we included about 8 studies, and of them, except for one study, rest of the studies all reported the 28-day mortality, which was the primary outcome of our study. So in terms of 28-day mortality, there was a small signal, very small signal towards benefit with the use of a targeted heart rate control. So most of the studies basically targeted a heart rate of less than 100 beats per minute using a titrated infusion of either an esmolol, landiolol, or in one study they used enteral rifaburidine, but that was the primary outcome of a study. So some small signal towards benefit. But in terms of the other secondary outcomes, like obviously the patients who received heart rate control agents, they had a lower heart rate, which is understandable. But it didn't really lead to an increase in norepinephrine requirements or a worsening of their cardiac index or increase in lactate levels or an increase in ICU length of stay, which was to some extent reassuring. But what we felt was that we also went ahead and then we did a great recommendation. We tried to analyze each of these studies in terms of their quality of the studies included. And we found that the evidence that we found in terms of even benefit with the targeted heart rate control was actually very low, was quite low actually in terms of the primary outcome, and very low when you consider all the other outcomes. Because of included studies, there were a lot of methodological flaws and there was heterogeneity as well, imprecision and other factors as well. We also did a trial sequential analysis, which is basically one way to find out regarding how this meta-analysis is, or draw inference about the meta-analysis. And we basically found that there was a lot of uncertainty in the results that we found. So basically what we suggested was that obviously this heart rate control might be tolerated from a hemodynamic standpoint, but the evidence is less certain than it was shown in the earlier studies by Morelli. And ideally, if you're using such an approach, you should ideally be doing it within the ambit of a well-designed RCT. And you should not be using it injudiciously in your patients.
Great. So recently there's one trial called as Landis trial. Does this study affect your findings or your analysis? Can you correlate both? Or
so that's a great question, because the Landis trial actually came afterwards, after the findings of while the article was under the peer review process. So we didn't have the option of actually including that Landis trial. So basically, we have actually tried to include the results of the Landis trial as well in terms of the 28-day mortality, and we have actually sent a correspondence to the journal IJCCM, and they're going to publish it in the next month. But basically, if I can tell you that actually it is not changing the results. If in any case, or if anything, this is actually reinforcing whatever we already found, that there's a lot of uncertainty, and there's actually no clear-cut strong mortality benefit with such an approach.
great. So how can you use your finding from the meta-analysis in our bedside practice?
So again, I think it's a very difficult question. It's a great question, but I don't really know how to answer that. What I would suggest is that obviously there is a clinical equipoise, and that is probably going to be there with this kind of a approach. Maybe if you're planning to do this, or if you're doing this, at least do it within the ambit of an RCT, and probably you try to explore patients who might actually show some benefit with the heart rate control. Maybe patients with a higher baseline heart rate, because there are studies which have showed that if the patient has an atrial fibrillation in the ICU with septic shock, we do treat it, right? Everybody in the ICU will give a amiodarone infusion or something to treat a supraventricular tachycardia. So similarly, if the patient has a very high heart rate, maybe in the range of 150s, 160s, maybe this approach might still have some benefit. So maybe we should actually try to design trials, trying to look at those clusters, and that might actually give you some better answers, rather than maybe giving it to everybody, maybe to somebody with a heart rate of 110 or 115.
Great, phenomenal. So what you told is that this meta-analysis is giving us a few answers as well as few questions as well as. So we are equally neck to neck with some questions and some answers, I think. Answering that question, we in that same subscription, we have a beautiful editorial by Dr. Kiran, actually, Targeted Heart Rate Control, a Promising Path and a Double-Edged Sword. I'll come to you, Dr. Kiran. What is your take on this article?
Yeah, so it's a very nice article, as it was already been described, and I applaud the authors, Riddhi and his team, for conducting such a beautiful meta-analysis and such a robust trial using appropriate tools like trial sequential analysis and grading system, which is not easy, and not many others have published such a robust statistical analysis tool coming from subcontinent. And using appropriate tools in appropriate setup is also important, and it is appropriate design. So what we could see and readers could infer from this paper is not the p-value which we need to focus on, because if you see this trial, the mortality for the p-value is significant. So what is important is to look at the confidence intervals and width of the confidence intervals. So if you see that the confidence interval, the width is quite large, and though it is not including the null effect, but if you see the trial sequential analysis, which is nothing but, if you see a meta-analysis is a pool of patients, and we are reanalyzing the outcomes. So basically, it's like a number of patients we are pulling up from each RCT and making a bigger study. That is a meta-analysis in brief. So using a trial sequential analysis, we can know whether the study is adequately powered, and whether there is any type 1 and type 2 error. So it is rightly delineated by the authors that the trial sequential analysis, the sample size is not reached. So that means there is a probability that still we are having a type 1 error. So falsely, we may be concluding that the mortality is significant. There is a mortality benefit, but it may not be. So that's what the trial sequential analysis suggests here. And also grading, that is the quality of the studies which can be delineated with this grade system. So it is again a robust tool designed by the Cochrane, which shows that, which the authors delineated that it's a low quality of evidence, which suggests there is a mortality benefit. It's a low quality. That is very important. So overall, my take on this article is, though in a research setup, there is a better targeted control of heart rate is happening, but still it may not be reflecting into a proper clinical hard outcomes like a mortality outcome yet. So however, looking at the previous studies, the mortality is not a primary outcome in many of the studies. So again, there is a probability of bias involved in that. So a larger trial is required to see mortality as an outcome. That's what I can infer from this. And also at this point of time, with the available evidence, it is not justifiable to use beta blockers or short-acting beta blockers in a routine clinical practice. However, in a research setting, yes, it needs to be explored further.
Very pertinent point you have put regarding beta blocker out of this whole thing actually. So, being an experienced person, you can tell us how better a study can be designed in future so that we'll get more answers than questions to you.
Yeah. As already I described, like many of the studies, one, there is a quality, like their robustness of the trials are not good. And the mortality outcomes are not the primary outcomes in many of the studies. And a lot of biases are also involved in these conducting of these trials, like starting from blinding, randomization, and also the sample size. These are the main limiting factors of that. So apart from that, if you want to do, someone has to do a future studies, probably what I can infer is we need to look at the specific subset of population, like population with supraventricular tachycardias, population with atrial fibrillation or flutters, or with the sinus tachycardias. What these drugs are short-acting beta blockers and how they are affecting this heart rate control. Because theoretically, if you control the heart rate or decrease the heart rate in septic patients, it can improve the diastolic filling time, and thereby it can improve your stroke volume. That's the physiology behind it. But it has not been translating till now to a mortality benefit. Why it is happening? There is a discrepancy of that. So that need to be explored. So what I can see is maybe a subset of population may be benefiting, maybe may not be an overall generalized population is septic population is benefiting from this intervention, is what I can infer at this point of time. So probably the patients who are septic, after adequate resuscitation, after adequate pain and distress control, still if they are having a persistent tachycardia, that means they're having autonomic dysfunction, probably that subset of population might have some beneficial effect. If you see, most commonly, if someone is septic and ICUs, and and when they have a supraventricular tachycardias, we give amiodarone, right? So that is a commonly used drug in someone who is hemodynamically unstable. So amiodarone works obviously as a beta blocker, as an initial mechanism of action. So already we are treating and we are doing that in a clinical practice. But what we are seeing is only beta blockers. What it does is what we want to see that. And also like future studies should actually focus on this subset of population along with a perfusion indexes, like cardiac output measurements may be useful, invasive cardiac output measurements, and also the perfusion, end organ perfusion is also important thing, whether that is improving by use of pulse indexes or NIRS monitoring. Probably incorporating such tools may useful to know and better understand about the heart rate control.
Wonderful. Very, very good take on that subject, actually. Thank you, Dr. Kiran. Last question to Dr. Riddhi. As I can understand from your tone, you must be gearing for another meta-analysis regarding this. So what do you think is the future direction for this research? What is the future in this research, in this field?
So as Dr. Kiran already has mentioned, so I really don't have much to add in terms of those things. I think we need to really now focus on specific clusters of patients rather than giving beta blockers or a targeted heart rate control to everybody with septic shock. So we need to basically focus on the higher heart rate groups. We need to kind of combine it with some sort of end organ perfusion to see adequacy of perfusion in terms of cardiac output monitoring. There are recent studies which have shown that actually aggressively treating the heart rate with, especially in the context of supraventricular tachycardias, and atrial fibrillation again is the most common rhythm, right? There is a recent study which actually showed that propafenone is actually better at rhythm control, and actually it improves the hemodynamics and the outcomes compared to even your amiodarone in patients with septic shock who have a non-dilated LA. So these are the kind of variations that probably we are going to look forward rather than a one-size-fits-all approach, which usually we tend to do a lot in randomized control trials. But again, this is the age of personalized medicine. So basically, we probably need to find out the clusters in which this thing will work. I don't think the results of this trial is enough to discard the use of beta blockers, but probably it should kind of stem more research in a particular subset in which probably this approach can actually have some good benefit.
Thank you. Thank you so much. Thank you so much, Dr. Riddhi Kundu, for giving us such a beautiful update. Thank you, Dr. Kiran Gudivada, joining all the way from Australia. It was a really honor on my part to have a discussion with you. Thank you so much. Thank you so much for joining.
Thank you once again for
Thank
inviting.
you. To my viewers, so keep reading Indian Journal of Critical Care Medicine. We'll again join probably next month around mid of the month. We'll give you about another article on the IJCCM. Thank you so much.